Hello, everyone. My name is Aurora Garza. I'm one of the hosts, and I'm here to introduce to you to Dr. Nancy McNamara. She is Valentina's epileptologist, and she's a wonderful, wonderful resource. So I hope that you find interesting what she's going to present. She's fabulous, and here she comes.
Thank you. Thanks for inviting me to speak today. I was very honored when I was asked to speak, 9 months ago or something. I'm really impressed by the way that you've been able to organize this. And I just want to start by saying that some of the studies that I reviewed in preparation for this did not have as many patients with 1p36 deletion syndrome in it. So I think there's probably a lot that you're all learning from each other and by sharing information. So I hope that this at least provides some information for all of you. It's really tricky to write a talk that covers such a broad breadth of information but I wanted to at least give you an overview, and I attempted to review all of the literature encompassing all the data that we have for children with 1p36 deletion syndrome. And it looks like it's about 200 to 300 children that have had information reported out on them. And that's in total, cumulative. I have no relevant disclosures. I don't get, kickback from any drug companies. I write a MedLink article that I get $50 from every year that I donate to our residents at University of Michigan. So the learning objectives and sort of the outline for this brief 45-minute talk, after which I will definitely leave time for questions, but I'll also stay afterwards if people have questions. So very importantly, despite the fact that your children are sharing similar deletion syndromes, every child is very different. And I think that's a really important thing to remember. So I wanted to just briefly touch on the facial features. That's not really neurological, but it's pretty adorable, that are shared features in children with 1p36 deletion syndrome. And then I'm going to give overviews about developmental delays, structural brain changes, and not all children with 1p36 deletion syndrome have epilepsy, which are unprovoked seizures, but can't ignore that one because that is what I do, take care of children with epilepsy. So I found a few review articles showing how adorable children with 1p36 deletion syndrome are, and I think those of you who are, this may be your first conference, you probably look around and think that a lot of the children look very similar or have similar features or maybe could be cousins or mini-me's. So they have very similar, what we call epicanthal folds, so folds around their eyes, sort of a kind of flattened nasal bridge, and some of them look like they don't open their eyes very wide. So something we call ptosis in medicine. So those are some things that you guys are probably looking around and seeing, perhaps for the first time. And in medicine, we try to not make all or nothing statements, but it looks like when people have looked at large groups or semi-small groups of children with 1p36 deletion syndrome, all of them have some degree of developmental delay. So that is one of the biggest things seen, and it's tricky because it's very variable. Additionally, almost all of the children have language delay, some more than others, with a large percentage of children not gaining much expressive language, so the ability to talk. It doesn't mean that your child won't talk, and it's really hard to predict something like that, but many of the children can't talk. But oftentimes they understand much more than they can say, as many of you know. It's about getting their words out, perhaps in other ways or with assistive communication devices. So again, so important that no one's going to be able to look at your child's genetic diagnosis. Additionally, and I'll talk about this next, even that combined with the MRI, no one's going to be able to look at those things and tell you what your child's going to look like in 5, 10, 50 years. We do our best, but especially in this syndrome, we're not able to predict things very well. We're just not that smart yet. And children can range from the inability to talk or walk, but I've seen lots of kids walking. I heard a couple kids talking. And outcomes are just very variable. There was even one report of a child growing into adulthood who could live on their own, which was amazing. But that's thought to be rare and the exception. And very importantly, I heard that I missed the talk by the geneticist, and I'm sorry that I missed that. I was working. But people are starting to really figure out, I think this geneticist who I missed the talk of is figuring out the correlations between different parts of the deletion in 1p36 and what that looks like clinically and physically. So one common feature that 95%, I love that stat, 95% of children with 1p36 deletion syndrome have is something called low tone. The medical term for that is hypotonia. And this seems to be the thing that gets a lot of these kids into trouble. And so what you'll notice is children just don't, it's not even just the strength, it's just kind of the weaker muscle tone. So harder time kind of standing on your feet, sitting upright. And these are two pictures. These children don't have 1p36 deletion syndrome, but they're good examples of, I think what's maybe seen as like being more flexible, just not maintaining uprightness as much as other children. The example, the picture on the left is something called W sitting. It's actually really hard to do this. I absolutely cannot do it. I have the opposite of hypotonia. But children with low tone will oftentimes do this. And then the picture on the right is an infant who, when you pick up an infant who has normal tone, they keep their back straight. But children with 1p36 deletion syndrome or kids with low tone, which is very nonspecific, oftentimes will kind of just be a little bit floppy and flop over. And so these might be things that you've noticed in your children from infancy, which tends to get better over time. So I talked about this a little bit already, but the vast majority of children with 1p36 deletion syndrome have language delay. And this is, variable. This is not 100% of children don't have language. In the small study that I found where they really kind of teased out some of the language, about, I think, 3/4 of the kids weren't able to attain any expressive language. And then I think 25% of children had primarily one word at a time, and just less than 10% were able to put two words together. That does not mean that your children will be in those cohorts, because again, what I worry about with all of these stats that I'm showing you is that in general, these were from relatively small studies. Hopefully this is something I actually had not seen before, and it was a really recent article. It's a little much for some people. This is mainly for Aurora. This is the slide I put in there for her. But it shows that with this deletion, there are lots of really important genes that are located in this deletion, and the geneticists are figuring out which genes are related to epilepsy, because not all children with 1p36 deletion syndrome will develop epilepsy, and two kids with epilepsy with this syndrome might look very, very different and have different frequencies of seizures. And then they're also finding out other structural brain abnormalities that I'll start to talk about that seem to correspond with having different genetic syndromes. This is my favorite paper. So the gentleman who took the picture, this is a really well-written paper recently that kind of teases out the best information that we have right now on 1p36 deletion syndrome. And then some children with this syndrome can also develop problems with their heart, which is a lesser known, lesser teased out thing. I remember even looking at this for one of my patients that I take care of just, 4 years ago. And there was basically nothing about heart conditions in children with 1p36. So that's kind of a newer finding. It does not mean your child will have cardiac issues. It's just something that's important to at least have their child screened for at some point. A very large percentage of children with brain malformation with 1p36 deletion will have some abnormality noticed on their brain MRI. And what I was explaining earlier is I think I would be really frustrated as a parent listening to this talk, because all of these are going to be vague and non-specific. And I remember having this conversation with one of my families several years ago, which is, okay, we can see these things, but I don't know what this will mean for your child. I don't know what it means. And it's not because I'm keeping something from you. It's just because structure of the brain does not always predict function. And that's an important thing to remember. But I at least wanted to go through a little bit of the terminology and just give you a little bit of background. Some of these your child might have. So the most common brain malformations or brain changes in children with 1p36, one of the main things is a small head. So we deem that something fancy called microcephaly. It just means that their head is small. That by itself doesn't mean a whole lot. But it means that for whatever reason, the brain is probably not growing at the same rate and overall is smaller. A large number of children with 1p36 deletion have abnormalities of the corpus callosum, and I'll show you a picture of this. But this is a connection in between the two hemispheres, and again, because this is the whole theme, very nonspecific. I can't look at somebody's corpus callosum and say that this means they're not going to function well on both sides of their body. It's really frustrating as a parent, I can imagine. Some children have thickened cortex, and I'll show you a picture of that and kind of what that means. Some children have little parts of their brain that didn't form well, which does put them at increased risk for other problems like seizures, but does not mean that they will develop seizures. Some children have a even more nonspecific thing of enlarged ventricles. They may have cysts or nonspecific white matter abnormalities. And so I just picked two of these things to just kind of explain what this means, but it just means that when we measure your child's head, which you probably remember if your child's not still an infant, but in infancy, their head gets measured at every visit, and we track that over time. And in children with 1p36 deletion syndrome and lots of other syndromes, their heads will be a little bit smaller, and sometimes it's quite small. And when it's quite small and below kind of the growth chart, then we deem that something called microcephaly. And then here's a picture of the corpus callosum. So this is, I'm trying not to show too many MRIs because I think they can be tricky unless you look at them all the time. But this is an example of a brain MRI. So this is just an example of looking at somebody's brain from the side. See that white thing in the middle? That's the corpus callosum. And that in that corpus callosum, those are the fibers that go from one side of the brain to the other and allow you to kind of coordinate movements and things like that. Importantly, if you don't have one of these, which some children with 1p36 deletion syndrome don't have, it doesn't mean you can't coordinate things. Maybe we'll explain if you seem to have more problems than other children, but it's not the whole story. And so it kind of doesn't mean much by itself. It might mean before a child has had genetic testing, and let's say they have low tone, if they're seen and we see an abnormality, maybe it doesn't look as white, it doesn't look as large, it doesn't look as well formed, maybe that would be a sign that we would screen for something like 1p36 deletion syndrome. But none of these things by themselves mean, oh yes, I see this MRI, this child also has 1p36 deletion syndrome. So it's not specific like that. And just reiterating, especially for those people who are going to be watching this later, most of the time, if I look at a brain MRI, I can't predict what that's going to mean for that child, especially in 1p36 deletion syndrome. And if I tried to predict it, I would probably be wrong. So I wanted to just touch on seizures. So about 50% of children with 1p36 deletion syndrome will develop seizures. The tendency to have unprovoked seizures is deemed epilepsy. And not all children with 1p36 deletion syndrome will have seizures, but they're just at an increased risk, about 50 times that of the normal population. So I thought it was worth talking about. Seizures are abnormal firings in the brain, and they're typically quite stereotyped, meaning each time they have it, they probably look kind of similar, and typically they don't go away without some sort of treatment, the first line treatment being medicine. Now, some of the malformations that we just went through place that child at increased risk for seizures, but not having them doesn't mean that you won't have seizures, and having them doesn't mean you will. Another obnoxious thing that I'm going to say today. I just wanted to show a picture of one of the things we talked about, which was this is a part of the brain that didn't form well. So this is an area of cortical dysplasia. The arrow is pointing to it. And in a child that has this, I would think that they would be at increased risk for having seizures from that part of the brain. This is a cross-section of the brain like this. The right is the left and the left is the right. And so I would expect that this child would have increased risk for seizures coming from back here on the right in the parietal lobe. And what's tricky is that depending on where a brain has a seizure from, you might see different things. And so one person's seizures might look different than another child's seizures. Not all seizures are like those that you see in the movies where children have generalized tonic-clonic shaking. Seizures can look quite different from child to child. And importantly, if your child does develop seizures, this does not mean that they're going to have frequent seizures every single day. Some children do, unfortunately. But most children who develop seizures will have those seizures controlled with their first medication. It just might have to be increased. When children have seizures that aren't able to be treated with the first medicine, the second medicine, and you're moving on to the third medicine, that's when we name it something called medically intractable or refractory seizures. We still use medicines, but oftentimes we'll go to other treatment options as well. So about 2/3 of children, or 2/3 of the seizures that children have with who have epilepsy are controlled by medications. But some children will require 2 or more medications. There are dietary therapies, something called the ketogenic diet or modified Atkins diet that we can use when people still have seizures despite 2 medications. And then there are even other devices, like something called a vagus nerve stimulator that we can implant to help control seizures. But again, my main message here is that even if your child does develop seizures, they may be pretty easy to control with medications. And why do we treat seizures? I just wanted to place this because, the cause, if your child develops epilepsy, is the 1p36 deletion syndrome. But why do we treat those seizures? It's because frequent seizures can have a negative impact on development, sometimes a negative impact on behavior as well. And, it's all a balance, but typically when we treat the seizures and get them to go away, it has an improvement on development. Children with 1p36 deletion syndrome have an increased risk for a unique kind of seizure called infantile spasms. And this may be old news to some of you. Looking around the room, I don't see a lot of babies here, but I at least wanted to touch on this in case you are a new parent or your child is still in infancy, just because this type of seizure, we want to recognize this early, because the earlier we treat it, the better the children do. And that's really, really well documented. So just a little note, don't want to scare anybody, but if you have a child who's young, who's an infant, and they start having stereotyped movements, this would be a time to call your doctor right away, because there are really good treatments that we can start early on to hopefully, that might actually really impact development. So it's tricky because I'll show you a video of what infantile spasms are. They're very quick, like 1 second long seizures, but they tend to cluster. Sometimes I'm an EEG reader, so a lot of times it's like every 10 seconds when I'm reading an EEG, I'll see the child have spasms. And the spasms themselves, people will say, well, that just looks like a little spasm. And I hazard to say lots of us have little spasms that are not epileptic, but in an infant, if they have a repetitive movement that's quite stereotyped, give your doctor a call right away. And so this is a YouTube video, but I use this like in other talks that I give, and it's a really good one. So let me see if I can find it. Alternatively, I have to demonstrate it. Nobody wants to see that. Let's see. Good. All right. It didn't like it when I transferred it from one computer to the other, but this is a really adorable baby. And he just starts doing these things where he kind of shrugs. Then a few seconds later, kind of shrugs. A few seconds later, he shrugs. All babies do a shrug, right? It's about the fact that it's occurring repetitively over and over and over again. And a shrug is non-specific. This could have been a look like this over and over and over again. And if they just do it once or twice, that's not a big deal. It's about if they cluster. So again, not to scare anyone, but that would be a time to just give your doctor a call that day or the following to do an investigation, which would be an EEG. So moving on from seizures and epilepsy, I was surprised that I couldn't find any good literature on the prevalence of autism spectrum disorder in children with 1p36 deletion syndrome. I have 2 children that I take care of, and they both have autism or autistic features. And I speculate the data is much higher than what I found. And it's probably because a lot of times people will say, well, the child has 1p36 deletion syndrome. That's the cause. It is absolutely the cause, right? It's the cause of them maybe having decreased eye contact or decreased awareness of social cues, of course. And I am pretty against giving labels just to give labels, but a lot of children, have a harder time kind of interpreting social norms, interpreting social cues, and could potentially benefit from ABA therapy, which is a specialized form of therapy for autism. I speculate the data that I found, which is that it's rare, is probably inaccurate. And I'm sure that you could probably even take a poll of children here and maybe get a better number than what I did not find in the literature. What I found more was just descriptions of behavioral issues that children with 1p36 deletion syndrome have, like temper tantrums. How is it only 22%? I'm pretty sure 100% of children have temper tantrums, but whatever. That's what I found. Reduced social interactions in about half. Stereotypies, which is just like repetitive movements of some sort. I'm not sure that I would call that a behavioral issue, but a stereotypy, a common one, is thought to be like hand flapping, maybe hand wringing. 34% of children have that. And then self-biting in about 30%. Again, I question all of this data, but that was the best I could find. And it was pretty recent, too. And then a thing that I didn't know until I did this literature review is that there are other things that we should be aware of. But what I was really looking for, and I think something that this group could probably do, is to come up with a set of guidelines. You guys actually have it on your website, but your website was the only website that I could find that gave some sort of guidelines. And it really, for a lot of rare syndromes, wouldn't it be nice to know screen for this, screen for this, screen for this? So screen for vision abnormalities, screen for hearing loss, which seems to affect a lot of the children with 1p36 deletion syndrome. But I was surprised that I didn't find, well, when do you have them see a cardiologist? When do you do an EKG? When do you do an echocardiogram? And I didn't really find that. I just kind of found random reports. I feel like we could probably get together after this conference and come up with some guidelines. Aurora. Exactly. So I hope you're not super depressed by my talk. You're all here because you have children or loved ones affected by 1p36 deletion syndrome. I want you to actually be empowered to know what to do. One of my favorite families, the mom came to a clinic and had this shirt on. It was the first time I'd ever seen it, which is Advocate Like a Mother, and I just love it so much. Advocate like a parent, like a loved one, like anyone. But it's about early recognition and intervention. It's tricky because we don't want to label our children, or, it's tricky because sometimes people actually have a lot of guilt about having a child with a chromosomal abnormality, with a genetic abnormality. This is not your fault, right? But we do have to sometimes give labels to things to get children the help that they need. And so acknowledging when you notice things, when you notice speech delays, motor delays, and then early initiation of therapies. So I would imagine probably all the children in this room or the ones over in childcare have had some sort of occupational therapy, physical therapy, speech therapy, behavioral therapy. Just keep those going and make sure that you're satisfied with the care that you're getting. I was trying really hard to find an amazing algorithm, but all of them are, you can't get them unless you pay like $150 for them anymore, of some of the guidelines that we use to help track normal development. I'm a pediatric neurologist. All I do is track development, and I cannot see it in my own child. I have a really hard time. I have to use charts all the time, especially when it's my own child, to be objective you can't compare your child to other children. You have to compare them to the norms. And so this is just an example of kind of normal motor development from the 1930s, which is still true today, about when you would expect a child to do certain things. And we have this for fine motor development. We have this for language development. We have this for all modalities of development. What else can I do for my child? Be on the lookout for seizures, and especially infantile spasms as you have them. Bring them up to your pediatrician, your pediatric neurologist. And importantly, this is something that I say all the time, just said it today in clinic. If it just happens one time and it doesn't happen again, I have no idea what that was unless I had an EEG on the child's head, unless it was, a pretty stereotyped movement, unless it was a generalized tonic-clonic seizure, then I know what that was. But if it's just like you did something funny and you fell asleep, I don't know what that was. I saw one of my patients today and I was like, I'm not smart enough to know what that was. But typically when a child has seizures, they typically become stereotyped, meaning they always tend to occur in certain ways, and they don't tend to go away without treatment. So bring those up and talk about them. I'd say be your child's advocate. Get your team together that involves your family members, your friends. I love groups like this. Again, I should have told you this, I'm not really a 1p36 deletion expert. It's actually kind of hard to be because all of you guys come from different areas, right? It's a relatively rare syndrome. And so, am I an expert list too? No, but I have to educate myself. And I think that I take care of primarily patient with epilepsy, and I have children with this rare disorder and this rare disorder and this rare disorder. And I'm honest when I say sometimes you'll know something before I do. And so bring that up to your child's physician. So sometimes families will notice a similarity. They'll notice, well, all of our children are on this medicine and they tend to do well. Or on the opposite side of things, well, on our Facebook group, on our group chats, we've all noticed that our children didn't do well when they went on this medicine. So don't minimize the observations that you make. And I think the great thing is it's 2023. We can all stay connected and make these observations together, come up with the guidelines together, and really take care of each other's children better. And then hopefully you don't think I'm a jerk when I say this, but try to do normal things. Try to do things that maybe are kind of hard to do as a family, right? So if your child's having a lot more seizures, gosh, maybe you don't go to the zoo that day, but try to do it on a different day, because it's still really important to do things as a family. If you have other children, to do things with the other children and try to live life to the fullest. And hopefully you don't think I'm a jerk for saying that, but I definitely take care of some families who it's really hard and they never got to that point where they were able to still do other things, and they let the child's, especially seizures, kind of rule their lives. I hope that doesn't happen to your family, because seizures can definitely rule lives, as can, behavioral issues, having a hard time getting out of the house. But that's not any of you, because you all got here. So well done. So most important takeaways is that just to remember that your child is unique, even though they may have the same DNA mutation as the child sitting next to them. And this support group is fantastic. Raising awareness is great. And I think you actually will probably go faster and find out things even more than some of the researchers do, because it's a great skill and a great power to have when you have people who care so much together like this. And so never underestimate the power of things like this. So my time is up, but I am, as far as my talk goes, I wanted to stop it earlier so that people who have questions feel free to ask, and I apologize if I don't know the answer.
So I have a question about the 1p36 versus autism and the commingling or separation of the two. It took a lot of fight for me to get the autism diagnosis for Gabe. And as everybody knows, Gabe does tend to be a pretty social bug, and I understand. But in the same aspect, it's like that fight because, as you said, to get ABA, which he needed to help him. So my question is like, where do we put the fight into? Like, do we fight more that you don't need an autism diagnosis to benefit from ABA? Or do we fight that we need, you know what I'm saying?
Yeah.
Like, why is it just an insurance thing, I guess, that we need that?
What a good question.
Yeah.
I think it's an insurance thing because it's really expensive.
Right.
How I explain this to other people is take a child with Down syndrome, right? We all probably know children with Down syndrome. The vast majority of those children have autism, and they seem to have no problem getting the diagnosis, right? Mm-hmm. It's because of Down syndrome. It's because of trisomy 21. In children with 1p36 deletion syndrome, just like other genetic conditions, it's because of that, but it's still a label that you give it because they would benefit from ABA therapy. Mm-hmm. I did not answer your question.
No,
it's an insurance problem, right?
Yeah, right. Yeah. And I think that is the hard thing is that, or like, to try to get it into papers that it's that yes, these kids do have on an autism spectrum. Just like you said, that it was like a 22%. I think on your paper.
I didn't even get a stat. It was rare.
Rare.
I was really surprised with it.
Yeah, and so I think it's just one of those things where it is, they're like, oh, it's because he has that genetic diagnosis. And I was like, anyway.
Yes, it is. Exactly. No, I do think probably a paper that says maybe the incidence is higher than that might be beneficial.
So I'm Rob Hopkin. I'm a geneticist. And there's a couple of issues that need to be sort of put on the table about this. One of them is that in many states, there is a legal mandate to provide ABA services and other things for kids who have a label of autism. So you need to fight for that because there isn't a mandate for that, even if your child has the same symptoms, but they don't have the label of autism. Now, autism is not testable with a genetic test, and you can have autism with Down syndrome, you can have Down syndrome without autism, you can have 1p36 and meet the criteria for autism. Some of those things are almost universal in 1p36, like having poor verbal skills, loving repetitive things. So many, probably most of the kids will meet that if they can be adequately tested, but the testing that we use is behavioral questionnaires, and it's hard to get reliable data on kids, particularly who have limited ability to act independently or to interact. And so we do have some difficulty getting that if somebody is going to be really strictly purist. I find that if you explain to the person that you're trying to deal with, I need this because it will benefit my child, then they will not lie, but maybe be a little bit less stringent with the criteria. It would be good, however, for us to publish some data on what percentage of kids meet the criteria for autism, for example.
That was a great answer.
And Dr. Hopkin will be speaking tomorrow. Dr. Hopkin, tomorrow.
So now I have more question about the communication in between the the neurologist community and the geneticist community. Like this is like we've been talking a lot in Valentina's appointments and all the things that she has, and I think because of like the many other kiddos with other syndromes or with epilepsy, it would be hard just to narrow it to how a 1p36 would behave with epilepsy. But I just wonder if there is like a forum or a space where both the neurologists and the geneticists meet and discuss, like, well, I don't know, these anomalies or these genes, how do they correlate to which medicines they have, or even to start saying, like, maybe that could help us identify which kiddos with 1p36 are more prone to have autism than others, or those guidelines maybe that we can start building together. And I think this 1p36 family is a very joint community, that it would be like a very easy group, I would think, to survey, right? Like we can give information about Valentina, like all her things, and I think other parents would be also willing to collaborate with that, so that all that data in the papers gets like more robust. Like I think we're over 1,000, or I think can say like 10,000 or so. Like a lot of families here in just the States, right? So yeah, that's just like a question was mainly, do you talk to each other?
It's an amazing comment. Yeah. So Dr. Hopkins, I think that his name. I'm sure he'll talk more about that, because you do a lot of research, correct? Yeah. Or are you too? Okay. Well, I can speak a little bit about it then from a clinician standpoint, which I am too. So it's a little bit different at every center. Who makes the diagnosis first? Typically a geneticist actually makes this diagnosis first. They comb the literature before they meet with you, because most likely that geneticist is also not a 1p36 deletion syndrome expert either, right? So they comb the literature to see what's been published, just like I just did. And so you're right in that it's great when we collaborate. I'd say clinically we do collaborate. I read their notes, they read mine. When there's an issue come up or I find a new publication, I will reach out to them and talk to them. But I think what you're saying, which is what I was saying too, just you're more articulate, is I think there's a lot more that we could tease out and be predictive of than what we are right now, right? Especially if we maybe share data, look at each other's, compare similarities. Exactly. Yeah.
I just have one question about the video that you couldn't show.
Yeah.
I have seen that in my son since, I would say about a year old, with that arm. He also, no, you can't play with the microphone. He also does like a thing with his mouth, and sometimes his legs will do this sort of the same thing.
Mm-hmm.
Is there, I know you couldn't pull it up, but is there any way that you would have like a minute to just kind of pull it up outside? So I could just take a look at it, because even my husband thinks that it's different from what you're explaining. And I've mentioned it to his neurologist,
Mm-hmm.
and his neurologist is not very receptive to things or concerns. So I was just wondering if that was possible.
Of course. Yeah, I would say the video isn't as important as the history part of it. So, for example, do the movements, are they stereotyped? Do they occur every few seconds? Do they cluster when the child wakes up or when they go to sleep? And still, sometimes I don't know, and I should just say, as some people in the room know, I don't know what that is. I need to see an EEG when they're doing it. Does that make sense? That's the way that you diagnose spasms and seizures. Sometimes we all know, but sometimes you can't tell unless you have an EEG on. But yes, absolutely, I'll come and show you the video, of course.
Well, that's kind of what my question is about.
Yes.
The EEG. Lonzo has had the testing, and things that we felt were neurological, they said didn't show anything, but also he wouldn't wear it very well. So I can't say that our testing was great. But we've also then had the geneticist said, well, it's probably he has an underdeveloped neurological system. So some of those things may be neurological, but may not show. Is that true, or is it, because now we'll show like a video to the neurologist to like, that's behavior. It's like, but is it, he'll stiffen those legs up and he cannot bend them until it works through. And it isn't necessarily triggered by, I'm mad at something or anything like that. He'll have those periods where he just, and she just insists that it's not seizure because we did the EEG, but it seems like it has to be something more than that because we know him and we know that it isn't behavior.
Yeah. Well, the main thing I'm hearing from both of you is that you're not really feeling heard. And I think that that's neurology 101, right? So it's tricky because I feel very strongly that you have to be on the same page. If they explain something to you and it doesn't make sense, then you advocate like a mother and you just say, you just say, I don't understand why this isn't a seizure, or I'm not sure based on the description. Does that make sense?
Is there such a thing, the underdeveloped neurological system? Is that true? I mean, is that even a thing?
Yeah, that's a thing. And so sometimes children will have movements that seem atypical, especially if they're jerk-like or spasm-like, spasm of a leg-like, and we record them on EEG. There's no change in their brainwave during it. Well, then that's typically not a seizure. And so sometimes we'll say, well, it's because they have an underdeveloped neurological system. Maybe it's because they have underdeveloped what we call myelination or white matter tracts. That is absolutely a thing for sure. Yeah.
So is that more just a kind of, you couldn't prove it was a seizure, but it appears neurological? We just couldn't go with that? Yeah.
Yep, exactly.
That's kind of what we thought.
Yep. And sometimes you just go with other treatments like, if it's related to tone or stiffness, then you'll use medicines for that. Yeah.
Okay. It exactly. It kind of, it comes and goes. So I don't know if a medicine would, right. He is on seizure medication.
Yeah.
It seems like it'll get more frequent as we feel he's building up to needing to have, because he has the tonic-clonic probably every 3-4 months. And so we're going to see more of this as we get closer, as we get further out from the last one kind of thing. Seems to be until we have till he has a rule, and then we kind of reset and go again kind of thing.
Yeah. I'd have to see what the brainwaves are doing during them to say. Yeah. It's like my mantra.
There was another question. So I'm going to ask a question for myself as I'm walking. What's your opinion on, so our son's 17, he hasn't had a seizure for a really long time. They've never been big tonic-clonic. And he's on Keppra right now. Hasn't had a seizure for years. But we've been really concerned with taking him off, especially during puberty, because we don't want, all of a sudden something to pop through and now it becomes easier for his brain to seize. What's your opinion on slowly, eventually weaning him off? Or do you just say, hey, we're going to leave him on indefinitely for the just in case?
Great question. Again, a decision that hopefully is being made with the family and not in isolation. But if a child has gone 2 years without seizures, then you get to question whether or not they still need to be on medicines. And how you question that is typically with an EEG to see if there are what we call epileptiform discharges or spikes or sharps on that EEG. In this room, we know the genetic cause, which puts them at increased risk for a breakthrough seizure. But at 2 years, I would say it's dependent on the EEG and the desires of the family, as well as any medication side effects that are being noticed. But it's let's say, best case scenario, the EEG looks really good. We don't see any spikes or sharps. I think it would be very reasonable to consider coming off of medicine as long as you have a safety plan, right? If there is a breakthrough seizure. And typically, though it might feel like the end of the world when you wean a medicine, typically you're able to get right back to the seizure control you were on before by reintroducing that same medicine.
Yes, I was just wondering if you could touch on some of the surgical options when you're down to surgical options above the BNS.
Yeah, good question. That's actually my primary job as a surgical epileptologist. So surgery is not something that I would just jump to in a child with 1p36 deletion syndrome unless they had a malformation in a certain part of the brain. Like the one picture I showed with the area where the child had cortical malformation, cortical dysplasia in the back. And if seizures seemed like they were coming from one particular area, it seemed like it was a part of the brain that could be taken out without hurting them, which, believe it or not, there's actually quite a few places in the brain where that can happen. Then you can talk about the pros and cons of surgical resection. But that's only if a child has intractable epilepsy, meaning they've tried 2 medications and they're still having seizures. That's when you ask that question. The details of what goes into a surgical evaluation. We should probably talk about, me and you, but because it can be quite complicated, if that makes sense, and is very, very individualized. Yeah. Good question.
Probably the last question.
Oh, we got two.
We have two.
Or I'll just come talk to you afterwards.
And now that we're talking about surgery, like what would be the criteria to choose one procedure versus the other? Like, for example, there's VNS or the corpus colostomy or the DBS. What would be the criteria to choose one versus the other?
So if your child has intractable epilepsy, meaning they're on 2 medicines and still having seizures or more, and let's say the seizures aren't coming from one particular part of the brain, let's say they're generalized or multifocal, these are the words that we use, it's actually dependent a bit on seizure type. So if the child has atonic seizures where they just drop to the floor, then typically corpus callosotomy, which is severing the connections between the 2 sides. Those sounds horrible, and horrifying is actually the best treatment, surgical treatment option for that. All the other seizure types, VNS is what you would go for next, because that's only FDA approved in children 4 to 18. So not 4 to 18, 4 and up, right? So that would be the next FDA approved thing. If the child is still having seizures after placement of VNS and, perhaps dietary therapy or things like that, we will use things like DBS off-label in those children, which is a stimulator placed inside the brain that help modulate or decrease seizures over time, over months to years.
2 minutes.
But you had a question for nine.
Okay.
Hey, just wanted to check on one thing, your thought on this. The last doctor we took Franklin to, said he had some sort of like freckles on his brain or something, but didn't have seizure activity, but didn't really explain too much into what that can be.
He said it was like a dark matter, just like different spots around his brain. He hasn't had any type of seizure activity, knock on wood, thank God. And then my question, I didn't know he had one, is he's on growth hormone as well. He's been on growth hormone since he was like 2 or 3. And we keep increasing that. And I know at some point we're going to have to take him off of that. But with him being 13 and increasing into puberty, what are the chances you think that he might potentially have a seizure or have some kind of neurological issue after we get him off of the growth hormone that he's been on since he was 3?
Good questions. So I'm going to guess, not having the MRI here, that those are nodular heterotopias, the freckles on the brain. That's when, should have shown a picture. I debated, I took the picture out. But you can have gray matter that gets stuck in development. It doesn't go out to the outer surface because our brains are covered in gray matter. It's supposed to end up out here, and it doesn't, because it doesn't migrate there. And so it doesn't mean somebody's going to have seizures. I might have them. I don't even know. You can see it in the general population. It's just if you see them and somebody has seizures, you say that, well, that's probably why, related to it. The puberty question, I'm glad you asked it, because I remember even when I was learning about child neurology, everybody's always scared of puberty in children who have seizures. It's kind of, it's definitely not something that's 100%, even 50%. I don't even counsel people on it much unless it's a young girl and she starts to have seizures around her menstrual period. It does not mean that they're going to start having seizures in puberty. I would say that would be the exception, actually. So, and again, the majority of the patients I take care of actually have intractable epilepsy. So it's not something that you tend to just see all of a sudden. So I'm not sure that should come into bearing at all when you're talking about growth hormone. Yeah, I'm not sure I don't think you should stress out about that too much as all the other things you have to stress out about. Importantly, we were chatting about this beforehand, the literature shows that in children with 1p36 deletion syndrome, they tend to have seizures starting in infancy. It does not mean that a child can never have a seizure, right? And it doesn't mean that they can't have adult onset epilepsy. But that's the vast majority of everything we know. And whether that's because those are the kids getting tested and those are the kids we know about, that's possible. But I'm not sure that should keep you up at night if you can try.
Thank you very much.
Problem. Thank you.